Hi, my name is Matthew McCormick, and this is my posterior postural assessment. I have Devin. She'll be helping me out with the posterior postural assessment. And we start by putting landmarks. We indicate certain biomechanical landmarks that we want to observe in the assessment. We'll go over them in detail as we go sequentially through the assessment, but just as a quick overview, we start by placing a marker here around C1, palpate the base of the skull. It's a little hard to palpate the cervical spine because it's deep to the ligamentum nuca in there. So we just go to the base of the skull midline there. We indicate a marker at C7, the spinous process of C7. Then we come down to about mid-thoracic, so T6. And then we have a marker here at the thoracic lumbar junction, so T12, L1. And then here at, forgot to put a marker on, at L3, just kind of midway through the lumbar spine is what we want. And we'll explain why in a moment. The PSIS, the posterior superior iliac spine, we want markers on both of those bilaterally. We come down, we have a marker midway through the calf, and we'll kind of go over how we measure that. And we have 3 markers going through the Achilles. So we start here with our visual observation. We want to look at the head, and a couple things that we're looking for in the head is earlobe level. We want to make sure that the ears are level with one another. Very rarely are people born with offsetting ears. So if you see offsetting ears, that'll be indicative most likely of a head tilt. And we can see on Devin, her ears are fairly level. However, her left is probably slightly elevated from her right. Another thing that we look for is jawline, and that we're looking for head rotation if there's excessive rotation there. And as I look back here, we can't see one jawline being more prominent than the other, so that indicates that her head is forward. The sternocleidomastoid, the scalenes, and the levator scap all can kind of contribute to these biomechanical dysfunctions. However, a little bit more specifically, and we get into this into the lateral assessment, if there's a forward head protrusion, that's indicative of some scalene tightness. If we have a little bit of rotation, if we have excessive rotation, that's going to be indicative of that sternocleidomastoid pulling and overactive and tight, pulling the head into rotation. If we see that head tilt, and Devin may have some head tilting because that left earlobe is slightly elevated from the right, that may be indicative more of that levator scap being tight on the opposite side. So once we've evaluated that, we come down to shoulders, and we're looking for level shoulders. We're looking for level shoulders, right? We want those even. And very rarely will you see somebody with completely level shoulders. All of us will have some sort of elevation unilaterally when compared to the opposite side. And as we look, I can place my hands here. We could use that as a marker. Devin has slightly elevated shoulders on the left side, and there's another marker that we can look at to confirm those findings. So that may be indicative of some tight upper fibers of the trapezius muscle, pulling that shoulder into elevation. When we come down, we're also looking generally, and we can palpate this too, for muscle bulk, right? And we're looking for uniformity in muscle bulk. And if we see maybe, some hypertrophy or inversely some atrophy on one side, that's going to tell us that we're biasing one side, which could spiral into many different things, maybe some neural compromise, what have you. If we see a little bit of hypertrophy, inversely atrophy when compared bilaterally to each other. But just looking at Devin and kind of palpating her muscles, they're fairly even, right? I'm not detecting any sort of discrepancy on one side or the other. So as we come down, we want to take a look at the scapula. And one thing we look for is scapular positioning with respect to protraction and retraction. Where do these sit? And what you can do here is you can palpate the medial border of the scapula, and then you can palpate the spine. And ideally, what you want to see is 2 inches of approximate distance between the medial border of the scapula and the spine. Devin, just from looking, and we can get the ruler out for our purposes today. Just a quick approximation with eye view will suffice. She's a little bit more than 2 inches bilaterally, so that shows that those scapulars are protracted. So we may have that forward posture, and we can see that a little bit more pronounced in our lateral assessment. But for here, you know, we can determine that she probably has some rounded shoulders there. Coming down, we have indicated with markers the inferior spine of the scapula, the inferior scapula. So when we look at them, we're looking for uniformity there. We would like those markers to be even. And if they're not even, once again, that could be indicative of a shoulder raise, biased unilaterally on one side. And actually looking here, this kind of confirms our findings from earlier. This inferior angle, I said spine earlier, inferior angle of the scapula is slightly elevated when compared to the right. So that would confirm our observation that that shoulder is slightly elevated. Also, scapular position, we're looking for excessive upward and downward rotation, and these markers can help us with that. So if we perhaps see this kind of skew off a little higher and a little more laterally from the spine compared to the opposite side, once again, that may be indicative of that scapula either upwardly rotating or downwardly rotating, right? So they look fairly, you know, with exception of that elevation, they look fairly even. So I'm not seeing any sort of pronounced excessive upward or downward rotation. Another thing with the scapula that we want to see and observe, is there any winging of the scapula? Is that scapula peeling off of that rib cage? Now, there's no ligamentous articulation there. It's held together by the serratus anterior and the rhomboids. So if we do see a winging scapula, we can suspect there may be some compromise to those structures with respect to the rhomboids, major, minor, and more importantly, that serratus anterior that stabilizes the scapula and peels it down to the posterior rib cage. On Devin, I can palpate some slight scapular winging here on the left side. So with the shoulder elevation and the winging scapula, you know, we can kind of conclude that her left side, you know, may have some biomechanical dysfunction there. True wing scapulas will have a very pronounced lift off from the posterior rib cage. I'm only detecting a slight lift off there. So we have these markers going down through the through the middle of her back at those spinal junctions that we talked about earlier. And from here, from C1 to C7 to T6 to T12, L1 down to L3, we're looking for those markers to be aligned with one another. And this is our scoliosis check. So if we see some curvature of these, if these markers don't line up in a straight line, if they curve out laterally, we can suspect that there may be some scoliosis dysfunction there. But looking at Devin, we can see that these are all fairly aligned with one another, and she's free of that compromise. From here, we want to look and just relax your arms to your side. So now we're looking at spacing between the arms. We want to see equal spacing when compared left to right, bilaterally. And it would appear that Devin may slightly have a little bit more on the left side. So I'm probably being a little nitpicky there. True excessive spacing, it'll really catch your eye. So true spacing may be more representative of this posture here. but you could probably see that Devin has a little bit more spacing on the left compared to the right. That can be indicative of a couple things, right? Most likely some lateral flexion, maybe some spinal lateral flexion. It can be indicative of a hip hike, of an elevated hip, elevated ilium. It could also mean maybe there's some dysfunction at the shoulder joint, maybe some excessive abduction, maybe some overactive muscles of the deltoid, possibly even the supraspinatus. So that's something we look for there. We also like to look at the elbows and the hands. Ideally we would like to see these elbows kind of point back at us. And if they turn out, which Devin's does, and you can see this fairly, they kind of move outwards, and that is indicative of some excessive humeral internal rotation. And if we could see that, the elbow is more kind of outward here as opposed to being straight in our eye line. And we can also confirm that, excuse me, when we do our anterior assessment, we'll take a look at thumb placement there, which will confirm our findings of either excessive internal or external rotation. More than likely, we'll see excessive internal rotation. That's the more common dysfunction with respect to things like upper cross syndrome and the protracted shoulders. Excuse me. We also take a look at the hands, and we can confirm our findings there. With our hands, we can see a lot of palm from our hands. Ideally, we should just be seeing that fifth metacarpal, facing us. We shouldn't see much of our palm in a neutral stance. Oh Lord. But we can see a lot of palm. We can see a lot of palm right here. Excuse me. So, as we're moving down, another thing that we want to look for is rotation, torso rotation. Is she rotating more to one side as compared to the other? It definitely looks to be fairly neutral here. Excessive rotation of the torso may be indicative of some internal external oblique overactivity there. And if she is rotated a little bit more, that arm spacing may also be a little bit more pronounced. But Devin's actually fairly neutral here, and I don't see any sort of excessive rotation happening there. As we move our way down to the hip complex, the first thing that we'd like to do is palpate the iliac crest, right? That proximal portion of her pelvis. And then we like to observe our hands. So I'm palpating right on the iliac crest, and I'm observing my hands for levity, right? To see if they're level with one another, which they are. So right now I don't suspect hip elevation or hip hike at all. We can also help confirm that because we've put markers here on her PSIS, her posterior superior iliac spine, and what we're looking for in a visual, with respect to, visually, that these two are lined up with one another. There may be some slight elevation here on the right, but that could also be, user error, operator error. I don't see any significant elevation there, and if you have a question, you can always palpate. Take a look at your thumbs and see if your thumbs are level with one another. And when we go in here and we palpate that that posterior superior iliac spine, they are fairly level with one another there. And if you need more of, say, a visual guide, the posterior superior iliac spine should be just distal of those dimples. If an individual has those dimples in their back, on the tops of their buttocks, just distal to that, you should be able to find their posterior superior iliac spine. So her hips are fairly level. We also look for pelvic rotation, right? Once again, if the pelvis is rotated away from us, or if it rotates towards us, that may be indicative of some external, internal oblique overactivity, given whichever respective side that may be. I won't get into it too much right now. But I do not see any rotation. I don't see any hip rotation. So that looks good. Coming down, we get into a little bit more sensitive area. This is hard as a healthcare clinician to palpate, especially on females. It may be an uncomfortable assessment for the athlete slash client slash patient. So you know, very much take that into account when you're doing your assessment. But you're looking at the ischium, right? The crease of their distal buttock to see if that they're aligned with one another. So we can take a look at the crease, right? If you have a trusting client, if you have someone who's comfortable with this maneuver, you can palpate the ischium. And once again, do a level check there. If we see, you know, an elevated ischium on one side, if those are disproportionate to one another, could be indicative of a hip hike, could be indicative of a leg length discrepancy as well. And you have to get into further analysis to differentiate which ones those are. Coming down, moving more distal. Now we move to the thighs. We're looking at leg bulk here. We want to see uniformity between right and left leg bulk. You know, excessive hypertrophy, and then you could even palpate to get the density of it. All right, is it actual muscle hypertrophy, or is it possibly some inflammation, which could be indicative of a compromised lymphatic system, and we're not having appropriate lymphatic drainage there, or we have acute damage to the area into which it's swelling and inflamed, and there's notable edema there. But looking at Devin, she's fairly even on both sides. We come down to the posterior knee, that popliteal fossa. Couple things that we're looking for here. I think the more prominent thing that we look for as healthcare professionals is general varus or general valgum, right? Bow-legged or knock-knee position. So when we look at the creases, they should almost make kind of like a slight smile. Okay, that's the natural anatomical neutral that we're looking for. And you can see Devin does have that, maybe a little excessive. You will, in general valgum, right, that knock-knee position, that smile will be much more pronounced. That lateral epicondyle may be really significantly higher than that medial epicondyle. I mean, the lateral should be a little higher anyway, but in traditional genuvalgum, that lateral epicondyle will be greatly significantly more raised, and you'll be able to see it too. It'll be a very pronounced sort of zig and zag. Devin looks pretty good. She maybe has like a slight sort of general valgum, and then general varum, that knock-knee, you'll see it comes out like a bow, which Devin is free from that. We also want to look at the popliteal fossa. We're looking at creases here. We want to see some normal creases. Excessive creasing may mean that she's lacking some extension and she stands in knee flexion. If that popliteal fossa is a little bit more pronounced, if you see sort of a rounded protrusion, she may be standing in static posture in a hyperextended position. You could also check for Baker's cyst here, which will pronounce like a very prominent ball. Devin, as I can see, has neutrality in all those respective dysfunctions or respective observations. No excessive creases, no excessive pronouncement of that popliteal fossa. So now we come down to the calf muscle here. And if you really want to get into it, you can use a tape measure, right? Use a tape measure. And from midline of her popliteal fossa, right, the posterior kneecap, you can find the mid bilaterally, you know, so you get the same marker on each side. Bring the tape measure down to her calcaneus. Find a midpoint in the calf. Arbitrarily, I'll say maybe it's 5 inches down here, 5 inches down here. That way you'll have uniformity on both sides, okay? And what you're looking for is for these to be uniform with one another. Once again, if we see one that is sort of protruding outward or inward, that may be indicative of tibial torsion, tibial external rotation or internal rotation there. I mean, possibly hip external rotation or maybe some anteversion or retroversion, but it may be a little bit more specific to tibial external rotation itself. And then we want to compare that. Oh, I'm sorry. You also want to check here, once again, like we did with the thigh muscle, coming down, checking for muscle bulk, make sure that those are even, that we don't see excessive hypertrophy or atrophy on one side or the other. And then we come down through the Achilles. We have 3 markers on the Achilles right here. We have a proximal marker, a midline marker, and a distal marker right here of the Achilles itself. And once again, we can compare that to the gastroc marker, and ideally we'd like to see those relatively in line with one another, right? And if they're not aligned, if they start to bow out a little bit, and we can observe that a little bit more down here on the on the posterior Achilles, these 3 dots should be fairly straight. And if we start to see a bow on one side or the other, that could be indicative of internal or excessive eversion or inversion. So we may see some flat-footed or high archness there. So looking, we can see that Devin does have some slight inward curvature, which is indicative of some flat feet. Right? You can even kind of get on the inside. I know this isn't really posterior, but you could take a look at the arches, where those arches land, where they fall. So we do have some excessive pronation there. So we call that pronation, which comes with being flat foot pes planus, the pes planus position. So she does have some slight excessive eversion. So one more thing that we want to look at is her feet, okay? And if you want to, you could have them stand with their feet together. Devin, can you stand with your feet together and just kind of stand normal? Thank you. And what you're looking for here is that you can see equally on both sides, equal toes on both sides. So if you could see the pinky toe on one side, that shows us uniformity. If we can see maybe 5th, 4th, and 3rd distal phalanges on one foot and only distal phalange on the other foot, well, that's going to show unilateral discrepancy on that side in excessive external rotation there, or excessive internal rotation inversely on the other side. If we can see beyond, if we can see too much foot, say if you can see almost all 5 of those phalanges, that would be indicative of some excessive external rotation, either stemming from the tibia or from the hip itself, which could be secondary to tight external rotators, or like again once said, it could be excessive retroversion if it's externally rotated, or excessive anteversion if it's internally rotated, and we'll see more pigeon-toed stance. But if it's retroversion or anteversion, both of those feet should be uniform with one another, because those discrepancies, those dysfunctions kind of happen uniformly on both sides. So that's something to kind of keep in mind. If it's just unilaterally, one foot is kind of rotating more than the other, well, then you can suspect, all right, maybe it's more soft tissue dysfunction. All right, so that is my posterior postural assessment on Devin, and look forward to your feedback. Thank you.